Yeah, the update in Beacon was very important. Another practice-changing trial, because we know that BRAF V600E mutations are targetable. We already had data that combining an EGFR antibody with a BRAF inhibitor was active in this setting. So Beacon was a randomized trial comparing conventional chemotherapy alone, which would be irinotecan and cetuximab, versus cetuximab plus a BRAF inhibitor with or without a MEK inhibitor. There was some preliminary data suggesting that dual targeting the BRAF and MEK pathways might be more effective than just a BRAF inhibitor plus cetuximab. The reason that you need the BRAF inhibitor is because when you, and BRAF inhibitors by themselves don't work. When you block the BRAF pathway, you get cyclic activation of the EGFR pathway. That's why you need to block the EGFR pathway. So this was a 3-arm study, standard chemotherapy, cetuximab or irinotecan, versus cetuximab plus encorafenib, the BRAF inhibitor, with or without the MEK inhibitor, binimetinib. So this was clearly a positive trial for the BRAF inhibition strategy. Both of the BRAF arms were superior in response rate, progression-free survival, and overall survival. This updated analysis, however, looked at comparison of the doublet versus triplet strategy in targeting BRAF. And although the response rate was higher for the binimetinib arm, 27% versus 20% for the encorafenib cetuximab arm, there was no difference in overall survival. So based on that, it's hard to justify a more expensive 3-drug regimen, even though there really wasn't greater toxicity. Quality of life endpoints were similar with 2 versus 3 drugs, but at the end of the day, there wasn't a survival advantage for 3 versus 2 drugs. So it's likely that the 2-drug strategy, BRAF inhibitor plus cetuximab, will be the pathway for potential approval of drugs in this setting. And I think we'll have a new standard of care in V600E mutant metastatic colon cancer. It will be an EGFR inhibitor plus encorafenib.